thought this article would be interesting to review. It's the Incorporating Functional Strength Integration Techniques During Hip Replacement Rehab. And it was an RCT. So the functional strength integration was something they'd used in, basically they wanted it to be a higher level rehab for people who'd had a hip replacement. So let's look at some of the details from this article. And each of the groups had the control arm, which was standard, basically doing gait training. The gait training of the control group used an assistive device, and the one in the THA got away from it as quickly as possible to focus on more use of the surgical limb. They also did, as they talked about, focusing on pelvic alignment and spinal alignment, working on the coordination there, and we're basically trying to promote good movement. They also focus more on strength training in the functional strength integration group versus the control arm, where they did therapeutic exercise but didn't focus on hypertrophy. Each of the groups did 14 visits over an 8-week period. In this article, they don't detail out the strength training program. You have to go to the article that was 5 years before, where they put forth the protocol. And they used machines, and they did 2 sets of 8 for each of the exercises they did. They didn't describe each of them there either. Maybe in a supplementary thing they did, but basically it was 2 sets of 8 with machines. And then they tried to integrate that strength improvement, functionally with cueing. And that was the difference between the two of them. The control arm, pretty standard. Let's walk, get you moving, doing some therapeutic exercising. The FSI program was more intense strength training using machines and trying to integrate it with a lot of cueing to get them moving without an assistive device and doing things normally and with good movement patterns more quickly. And so then the question is, how are they going to know if it works? Well, 6 weeks, which is midway through the intervention. That's when they had their first measurement, their first outcomes measurement. Then the primary one was 10 weeks after surgery, which was the end of the intervention. And then we have the 6 months. As you can see here is a 8-week intervention area, and this one has it at the after that. That's when they did that's when they had their primary intervention at 10 weeks. So they just did it 2 weeks after the intervention, so pretty close to after, and then a 6 months. But it was the one right after the intervention was the primary outcome. And they primarily used a 6-minute walk test afterwards at the post 2, which was the primary one that they were looking for. So now we're going to go down here to results, and basically said there wasn't really any difference between the groups. We're going to look at some of the details of those that weren't any different. So 6-minute walk test improved in both of them. As you'd expect, somebody does 14 visits of anything that's beneficial, working on walking, any type of exercise. They're 10 weeks, I believe it was, after surgery, or let's double check that. 10 weeks post-surgery. They've done 8 weeks of training. They should be doing better, and they improved by 60 meters in the 6-minute walk test, whereas the FSI, got 12 more meters than the control group. They said that wasn't statistically significant, but the point estimate was 12 more meters there. Then we look at the secondary outcomes, and that was at the end of the intervention period. They didn't detail whether these people kept doing it in the coming months, the 4 months later when they did the 6-month time period one. Then they also did one of the other assessments they did was a functional gait assessment. The control group improved by 1.63, the functional strength group by 3.34. Again, they have it as they had that one as statistically significant between the two. And that was at the midway point. So earlier on, the group they felt pushed more, got better more quickly. But in the end, it didn't really matter because it wasn't statistically significant at either of the other time points that they looked at. And so we can scroll through there. Oh, and then one other one, the single leg stance from pre-surgical to when they looked at it at the first time point, midway through the intervention period. The control group improved by 0.7 seconds, so not even 1 second, while the FSI group improved by 5.18 seconds. And I think that was statistically significant. Yes, it was. So basically what their primary outcome was didn't hold up, which was the 6-minute walk test. A few of the other ones that weren't at the main time points and it was earlier on, they were statistically significant, which was disappointing to the authors. And as I look at it, my take is if we do 2 sets of 8 on exercises on machines, and we push them a little bit harder with walking so they don't use an assistive device, those people should do a little bit better. But everybody's improving in both of these groups. And so maybe our patients need different types of exercise. Maybe they need 3 or 4 sets on more functional type of exercises. And maybe we don't focus as much on cueing for the neuromuscular or for alignment. We just need to push them higher level with functional strength training exercises versus machine exercises and do more sets. And maybe there have been larger differences. We also need to recognize some people need more rehab than others. Some people do quite well with very minimal rehab, and some people need more rehab. And so push the people that need to and make sure everybody hits their goals, whatever it may be. Also, on that primary measure, the 6-minute walk test, strength training isn't necessarily better for walking. We need more endurance for walking. And they were looking at hypertrophy training, and those two don't necessarily align. There is some crossover that it can be helpful for it, but if they would have looked at maybe pushing them harder or more endurance-based activities, maybe it would have helped out with their 6-minute walk test. So again, it depends on what our patient's need is, but we need to recognize that just throwing anything at them will be helpful. The more specific we can get for the patient, the more help that it can be.